I'm Oscar Valencia. I'm an anesthesiologist in this hospital, in the 12th October Hospital. It's a big hospital, a university hospital with about 1,000 beds, and I'm the person responsible for difficult airway management. Yeah, I'm sure high nasal flow will have a benefit. I'm sure it prolongs the safe apnea time period. And that's a key point in many types of patients, situations, and in difficult airway management, just have 2 minutes more to work. It can be a world. Well, if I'm able, I will try to use high nasal flow cannulas in all types of patients, because if I have something that can prolong the safe apnea time, it will be wonderful for me. But if I have to use it in some patients in particular, I think I will use it in all type of patients that we think pre-oxygenation won't be enough, because we have high metabolic oxygen consumption or high metabolic rate, or because maybe we have a low functional residual capacity, and we will have problems with this type of patients. Maybe they are not difficult to be intubated, but they are difficult to face max ventilation, and we will have problem in SpO2. I think the first time you are using high nasal flow cannulas, you must be sure you won't have problems with the rise of PCO2, because maybe you have written a lot about that. Hypoxemia can be prevented, but with the problem of elevation of PCO2 levels. So when you see in the same time that you don't have this type of problems, and that this type of problems can be resolved when you do a little bit of bagging, well, you feel more comfortable when you use the technique. Yeah, I think that's a key point in pre-oxygenation. You know, when you see the way the curve of SpO2 is, you have a big or a large place where SpO2 is always 100%, but maybe you are in one part that PO2 level is just over 100, and you can be in the other side over 300. So maybe you can put the patients in the flat part of that curve, and you are more comfortable, you have more time. Now we are just doing things, but we don't have nothing, or nobody has told us what to do. Maybe we can pre-oxygenate the patients 5 minutes, 4 minutes, 10 minutes, we don't know. If we know when we are with the patient in the 400 PO2 level, maybe we are safer. We have been seeing that when we are using PCO2 monitorization, if we use the bagging, PCO2 level decrease a little bit, or at least it doesn't increase too much. So we can use it every time we need it, if we have it. I think that's the most difficult part, because we don't know how long must we do the pre-oxygenation. We don't know with which percentage of oxygen to use, and which position we must have the patient to have a good point. So there are many variables, which type of patient. So we have a lot of work to do.